Okay, there.
We can start now.
Okay. Good morning, everyone, or good evening, good night. Welcome to the Zoom webinar for the Tribute to Life project. And the topic today is transplantation, living kidney donation. Today we have as chairs myself, Margaret O'Shea, the Caribbean coordinator for the Commonwealth Tribute to Life project. We have Ms. Lisa Burnapp, Associate Medical Director of Living Donation, Blood and Transplant UK. Our Dr. Nerissa Jurawan from Barbados, also Birmingham at one point, consultant transplant nephrologist at the Queen Elizabeth Hospital in Barbados. We also have Dr. Peter Hughes, the lead physician for transplantation at the Royal Melbourne Hospital, Australia. Welcome, everyone. You can put questions in the Q&A or in the chat, and we will answer your questions as the presentations go on. I would like to introduce first our first speaker, Dr. Nerissa Jurawan. Nerissa was awarded the Bachelor of Medicine and Surgery from the University of the West Indies in 2000. And she initially practiced in Tobago of the West Indies and then moved to Birmingham in 2009 to continue further training in nephrology. She was awarded the MRCP in nephrology and also received specialist qualifications in 2016 in nephrology. She then went on to do further training in transplant nephrology before migrating to Barbados, and she's currently consultant transplant nephrologist at the hospital in Barbados. Welcome, Nerissa, and we're looking forward to your presentation.
About transplantation in Barbados. Thank you, Margaret. I'm just going to share my screen. Right, is that good?
Perfect,
Yes.
Nerissa, thank you.
Everyone can see? Okay, great. So today I'm going to discuss a little bit about renal transplantation in Barbados. So we're going to look at the problem of end-stage renal disease and chronic kidney disease in Barbados. And then we'll learn a little bit about the history of renal transplantation in Barbados. And then I will look at the current transplant program. And I thought it would have been interesting to hear my perspective, having come from a developed country, spending 10 years and completing my training and working as a consultant at the Queen Elizabeth Hospital, Birmingham, compared to transplantation in a developing country with a program in its infancy stages. We'll go on to look at the development of transplantation of the program in Barbados afterwards. So, as you all may be aware, Barbados is a lovely little island, the most easterly island in the Caribbean, roughly a population of 300,000, and it's about 167 square miles in area. The GDP of Barbados per capita is about 15,000 USD. GDP in UK per capita is about 41,000. The average life expectancy in Barbados is 79 years. And of course, we all know it's a developing country, and it's similar to the NHS in England, where the National Health Service is paid for by the government and taxpayers. So there's one major hospital, the Queen Elizabeth Hospital, one private hospital for ambulatory surgical centers. There are about 8 polyclinics to service the medical needs of the population and 2 private medical clinics. So unfortunately, there is no structured renal registry. So I can't give you the exact data for the chronic kidney disease population, but just as an estimate, the clinic population is about 1,000 patients. Today's actually my clinic day. We see about 55 to 65 patients per week in the clinic. Referrals average 6 to 8 patients per week. This is outpatient. And in an inpatient setting, it's roughly about 5 per week. We usually discharge 1 patient per week, and embedded in this chronic kidney disease clinic is the low clearance clinic, where we try our best to transition patients onto dialysis. However, most of our patients are unfortunately crash landers. Currently, for the renal replacement therapy, we have on average 300 patients on hemodialysis and 100 on peritoneal dialysis. So much, it's stuck. Goodness. Pardon me. What has happened here? Okay, great. So as with everywhere else in the world, the burden of chronic kidney disease and end-stage renal disease is becoming more and more of a burden, and that's because of the growth of the non-communicable diseases such as hypertension and diabetes, which unfortunately are very rampant in Barbados, along with obesity. So we've seen a rise in we expect this figure to grow within the next 5 years. So currently in Barbados, we spend 12% of the health budget on dialysis, which is a huge amount given the population and the fact that it is a resource poor country. So renal transplantation really is the way forward in order to help alleviate this problem, along with proper screening to stop the progression of chronic kidney disease, which is why this program is so very important. So we all know of the benefits of renal transplantation as opposed to remaining on dialysis. And this, of course, is a better quality of life for the patient, better survival. However, in terms of the cost benefit, we can compare, if we just look at the cost of hemodialysis, peritoneal dialysis compared to renal transplantation in Barbados, it equates to a saving of about 23,000 Barbadian per patient per year after year 2 of transplantation when compared. The benefits of a renal transplantation program in Barbados are huge. So looking at the renal transplant history of Barbados, the first transplant occurred in 1987, and the surgeon was Professor Waldron. Between 1987 to 1995, there were 9 subsequent transplants. Then between 2009 to 2012, 3 transplants, all living donors. From that cohort, the majority are alive. The longest surviving transplant is 21 years. After 2012, the program went into a bit of a hiatus, and the core team at that time was 1 surgeon, 1 nephrologist, and 1 part-time coordinator. Again, my computer is lagging. Oh, goodness. Right, so sorry, the slides seem to be.
I'm not sure, Nerissa, is whether it's in the if you come into the Zoom window, or if there's little arrow keys as well. Sometimes that works a bit better. Or your physical button to left and right.
Yeah, I'm using that, but it's not.
Is there an arrow at the bottom left?
No. But it wasn't giving this problem before, so I don't know.
It's sometimes just an internet issue.
All right, here we are. Probably it is. Okay, so I went to Barbados with the Transplant Link community in 2015. And we performed the first transplant in 2015. Okay, we're stuck again.
Perhaps if you escape out, if you push escape in and come out of the presentation, it might work better for you.
It's yes.
Might be a Wi-Fi issue indeed.
Sorry?
It might be a Wi-Fi issue indeed. I don't know.
Yeah, it probably is. Because nothing is happening. I'm pressing escape and oh
Well, there's
dear.
some things at the bottom left. If you look at the bottom left, there's some.
You're good. You moved again.
I think it may be a Wi-Fi. So I'll try to speed up while I have the slides. So 2015, we partnered with Transplant Links charity. 2020, we've done 10 successful transplants thus far. Of course, we've had a lull in activity due to the pandemic, as all our resources were converted to fighting the pandemic. And we have restarted in 2022 with a successful transplant performed in the month of May. So far, we've had very successful outcomes. Unfortunately, we've lost one patient at 1 year from PTLD, and another one suspected cardiac disease. We actually passed with. So just to share my perspective, having worked in both a developed and a developing country, these are the Queen Elizabeth hospitals. Of course, this is Queen Elizabeth Hospital, Barbados, and this is Queen Elizabeth Hospital, Birmingham. So we'll just speak briefly about the Queen Elizabeth Hospital, Birmingham. It's one of the largest renal services in the UK, servicing about a catchment area of 1.7 million. There are an estimated 25,000 outpatients, 1,000 patients on dialysis, and they perform roughly 180 to 200 transplants per year, which figure may have gone up drastically since I've left. Roughly, while I was there, it was about 45% live donation, 55% deceased donation. There were 622 patients on the waiting list. So, of course, with such a huge unit, there was adequate staffing, 25 nephrologists, 10 transplant surgeons, 8 transplant coordinators, clinical nurse specialists. There were clearly defined pathways, superb support services, laboratory, radiology, tissue typing, and of course, the deceased donor program. In order to create more opportunities for live donation, there was the ABO incompatible and paired exchanges. So the current resources at Barbados, there is one surgeon, one surgical registrar, 2 nephrologists, a nephrology registrar. There is a transplant coordinator who has been made full-time since June 2019. In 2019, we also were lucky to get one office and a consultation room, because prior the patients will be seen down at the dialysis unit. And I was very worried about that, of course, because of infection control. And in 2018, we established the Independent Assessors Committee. And this is a diverse group of about 12 persons, and their job is to oversee transplantation and to ensure that it is done ethically. We have been allocated a project manager this year, so hopefully, we can take the program forward. So this slide shows exactly how I feel whenever I embark upon a new transplant in Barbados. I take a deep breath and just dive into it and hope for the best. So just a bit of background, because we have an excellent team. Everyone is very dedicated, hardworking, but because of the lack of resources, it's very challenging to work under these circumstances. I'll give you 2 examples. Just 2 years ago, the last transplant that we did before COVID, he developed acute antibody-mediated rejection, stopped passing urine on day 2. Quickly had to do a biopsy after 5 days. Send the biopsy over to Birmingham because we don't have the resources to process our samples in Barbados to get an adequate biopsy report. So waited on that result. And then there was the question of how do we treat this? So I started with intravenous immunoglobulin and rituximab because that's what I had immediately. Had to order in ATG. At the same time, tried to get a part into the island to enable the plasma exchange machine to work. Finally, we got the plasma exchange up and running. We plasma exchanged him, and now he's doing brilliantly with a creatinine of 135. Our last transplant in March, we took care of this patient without tacrolimus levels because the machine was down. And we had to send samples away, wait about 5 days to get a result. So this is just to give you an idea of our challenges. But what I've recognized is that because this program is so very important to the patients with end-stage renal disease, we have to develop it, and it's worth all of the challenges and all of the stress, because oftentimes these patients, because there's no deceased donor program, this is their chance for a normal life, for a better quality of life. So it's worth it when you make it to the other side. So having said that, what we do need is an establishment of a national transplant unit with an allocated budget, adequate staffing, the infrastructure in order to create a robust living donor program. We also needed the establishment of a renal registry, so we have exact data on the problem, so we can plan ahead within the next 10 years. We also need a transplant waiting list. We need development of support services specific to transplantation, particularly the HLA typing, adequate pathology support. We also need to continue to build awareness, encourage donation, and what I think is very important, and what I've recognized having come back to the Caribbean, is that this lack of resources is not peculiar to Barbados. Certainly it runs throughout the chain of the Caribbean islands. And I would like to see within the next 10, 20 years, greater collaboration between the countries in order to pool our resources and share organs. I'm about to share with you just a little data on a survey that I've started at the dialysis unit. And it was just to give me an idea of the scope for living donation. So one rate limiting factor with living donation at the unit is that if you look at this slide, the family history of most of the patients on end-stage renal disease, they have a very high family history of hypertension, diabetes, chronic kidney disease. So that is certainly a barrier for their relatives stepping forward to donate, because oftentimes they're not suitable, as you can see here. So what we really need, in the future, after we get the live donation program up and running properly, is the development of deceased donor program. Right now, we need legislation. So in Barbados, there's no legislation which allows you to donate your organs. So we need a legal framework for transplantation. We need a Human Tissue Act to be passed in Parliament. We need a legal framework for brain death legislation, for living wills and advance directives. And thankfully, this is now shortly. So in summary, Barbados has begun to re-establish the live donor program with the partnership of the Transplant Links community. We still have great strides to go for the development of a structured, efficient live donor to benefit from a deceased donor program. Thank you for your time, and I'll leave you with one of my favorite beaches in Barbados. Any questions?
Thank you. Thank you very much, Nerissa. I've always said you're an optimist because, as you said, you take a deep breath before every transplant. But I think it's important that we keep going, and when you're optimistic like yourself, for some reason, everything comes good at the end. I suspect this may have happened when all transplant programs were started worldwide.
Yes.
I'm not sure where everybody is from the attendees. Does anybody have any comment to make?
Margaret, there are a couple of questions coming in on the Q&A. One we've picked up in the panel from Alice about relevant article. I'm just thinking about, Alice, the best way to respond to you on that. And a question from Deepika saying, in case of deceased transplant, is there any list of do you keep a deceased donor list for transplantation in Barbados?
Sorry.
Yes, do you have a deceased donor transplant list in Barbados?
No, we don't. We don't.
Um,
We don't have an active list of recipients. We don't have a waiting list, and no, we do not, which is something we need to develop.
so
Was there a hand up?
yes, I'm not sure whether or not I think if you have a question, I don't think you can really put your hand up. So I think you need to
Okay.
just pop it in the Q&A if possible. Basically, and how long an organ can be preserved, but that's probably more relevant to the deceased donor transplant program. But you might want to comment from the living donor perspective, Nerissa.
So right now, currently we are performing living donations. So we haven't developed any of the services for deceased donation and deceased procurement. We use, Margaret, when last we did the transplant, it was the University of Wisconsin fluid that we used to perfuse the organ. And, you know, it's a matter of an hour between retrieval and placement and the transplant surgery. It's never been longer than that. Has it, Margaret? Right. Of course, we don't have perfusion pumps or anything like that. So.
Yeah. I think
Okay, thank you. I just
yes, I think that closes the
Lisa.
question.
Sorry, go ahead.
No, that I was just checking the Q&A again. There are no further questions.
Oh, one last one. How do people register themselves for organs in Barbados?
Again, because there is no legislation, that is not possible. That is what we hope to achieve. We are hoping for an opt-in system where as in the UK, you know, you register when you go for your license, or, you know, there's an advance directive. But right now, there is no system in place.
I think perhaps we can pick up some of these wider discussion points after the second talk and involve both our speakers in that.
Okay, so I'll hand over to you now, Lisa, to introduce Peter to the.
Thank you, Margaret. So it's my great pleasure to introduce to you Dr. Peter Hughes. Has been in Australia, but he's also the clinical director of a program that's extremely dear to my heart in kidney exchange programs, and is going to talk to us something and bring his expertise to this session in donation in general. So Peter, over to you.
Lisa, and thank you very much for inviting me to speak today. So I'm just going to share my slide. All right, so
Yes,
thank you very much again for inviting me to speak. So as Lisa just mentioned, I'm the director of what we call the ANZKX, so the Australian and New Zealand Paired Kidney Exchange Program. I'm based in Melbourne, Australia. That's a photo of Melbourne. That's as nice as I can make it look. So I'm just going to give a little bit of background to paired exchange program, and more recently has become a joint program across Australia and New Zealand. So this is just a little bit of background, I guess, from an Australian perspective. We have an Australian and New Zealand database, which captures all of our dialysis and transplant patients. So this is just looking at Australian deceased donor and living donor transplants back from when our last report was released. So just over 20% of transplants in Australia are living donor transplants. So it is an important part of our transplantation activity. I guess that figure varies a lot from place to place, but that's what it's been like here. And living donor transplants are important, partly because there's a significant benefit to them, and this is Australian data, just looking at also graft survival with living donor transplants is better than deceased donor transplants. So just as a single figure, at 5 years, there's 91% of the living donor transplants working in the most recent report in Australia, compared to 83% of the deceased donor transplants. But there's certainly barriers to living donor transplantation. One of those is having a suitable donor, but even with a suitable donor, many of these donors are incompatible with the person that they wish to donate to. And so incompatibility in this terms really means either blood group incompatibility, which is a common cause for a donor not being able to donate directly, or having a positive cross-match, which means HLA antibodies, essentially. And so there's a number of options, I guess, for people who have a living donor, but they're incompatible with them. One is, if they're blood group incompatible, is to go ahead with a direct blood group incompatible transplant, which is a very successful procedure, although it does require extra treatment, usually around the time of the transplant, and because of that, carries some additional risk. So this is one of the larger outcome studies of blood group incompatible transplants, and this showed that there was an increased death rate in the first year after transplant due to infection related to the additional treatment that was required. For people with HLA antibodies, they can have transplants, direct transplants, but there's a higher risk of antibody-mediated rejection and graft loss, which brings me to the next option, which is a paired kidney exchange, which I think most people probably are familiar with. Here is a cartoon just to try to illustrate it. So we have a donor here and a recipient here. This is their blood group, and they've got incompatible blood group. We have a second cross match. And if this donor donates to this recipient and this donor donates to this recipient, then we can get around these incompatibilities. Both recipients receive a transplant, and that's the basis of paired exchange. And so if you set up a paired exchange program, you need essentially a whole lot of these incompatible pairs. A collection is what we call our pool of donors and recipients. And then you need to try to create chains and loops out of these pairs. Actually, I won't spend time on this, but there's different types of chains or different types of matches that you can make. These closed loops, which can be 2 ways, 3 ways, or bigger, and the non-directed altruistic donor chains, where you have a single donor to start with, and at the end of that, you have a waitlist recipient. I might just skip over that because just in the interest of time. So to talk a little bit about the program here, so this is now Australian and New Zealand paired kidney exchange program. It actually began as the Australian paired kidney exchange program, or AKX, back in 2010. And this was established by Paolo Ferrari in Australia at that stage. And so it's a single national program for the whole country with a national coordinating centre, and that moved to my hospital back in 2017. Fundamental, I guess, concepts underpinning this program, I've just summarised here. They are that the donors and recipients have to be fully evaluated and consented before they enter the program. And particularly for the donors, there's a very detailed, standardised criteria that the donors have to meet to be able to enter the program. And that's a very important part of it. The donor operations we've always performed simultaneously when they're in the closed loops. We don't do that with the altruistic donor chains, which I can talk about if people are interested in that. We have, it's quite Australian. This idea here is quite important. So the donors will have their operations at their local transplant centre where they're assessed, and then we transport the kidneys around the country. So that's a logistical challenge, but something that is part of the program. And the program began by having 4 match runs a year. And the match run is a time point during the year when you try to create chains and matches out of the pool of donors and recipients. So I've just got some more, a slide about why we move the organs when we don't move the donors around the country. There's significant benefits to that. It means that the donors can be assessed at their local transplant centre, and then the same team perform the operation. If you have a donor who's assessed in one centre and then moves to another centre, then you start to run into problems where the opinion regarding the suitability of the donor differs, and you can have people who then declined or aren't able to go ahead with their donation. It means they also know the transplant team, they can remain anonymous, and they can stay in their local area where they have support of their family. The challenges, however, are that we then need to move the kidney around, which involves couriers and flights and a lot of planning and organisation. And essentially what we're trying to do is limit the cold ischemic time. And we try to limit that still to under 12 hours. That may be a little bit too stringent, and there's pretty good data to suggest that up to 16 hours is okay, but we still aim for less than 12 hours. Another thing that moving kidneys means is that the transplant centres need to have a lot of trust in each other, and that's because they're putting kidneys in when they've been taken out by a surgeon at another centre. I think it's probably created a good relationship between many of the centres in the country. So I've just mentioned how the program was set up, and there's been some evolution in the program since then. So in 2019, so Australia had its own program, the AKX New Zealand, which is a nearby country separated by the Tasman Sea, also had their own national KPD program, and we joined the two programs to form the ANZKX. So we make chains either in each country separately or chains which cross between the countries, and we transport the kidneys across between the two countries, again with the donors having their surgery in their local centre. So we started doing that in mid-2019. Unfortunately, by March 2020, we had to stop as all the borders closed, and we're hoping to restart that soon. Again, just to talk about paired exchange programs in general, this is an old paper now which gives an idea that as you increase the number of pairs in your pool, your ability to create matches increases, particularly, well, perhaps once you get up to 50, that starts to level off a little bit, which is possibly a useful concept. So for the Australian program, we had a gradual increase in the number of pairs in each match run. Each of these bars is a match run with either 19. We joined with New Zealand, so there's a further step up there. These are the number of transplants performed per year in the program, which was increasing, maybe it leveled off with COVID. And so this is the number of people who have entered the program so far. We've had a rate of transplantation around 55 to 60% really for some time now. And so this is other outcomes for people who've entered the program. The majority have been transplanted through the program. Some have received a transplant from another living donor or a deceased donor, or are still waiting, with a small number of people who've been removed from the program because they've become unfit or for another reason or died. Most people who enter our program do so due to HLA antibodies. Varies considerably really from program to program or country to country. This was significantly higher, but has come down over time, but I won't go into that. So most people have HLA antibodies. And so that means that a large proportion of people who enter our program are sensitised. You can see almost a quarter have a CPRA as a measure of sensitisation, which is over 97%, and 36% have a CPRA that's over 90%. So a sensitised group of patients, which makes them a difficult to match group of patients. And people's level of sensitisation is important in looking at what their outcomes are in the program. So our rate of matching and transplanting people is quite good across a range of sensitisations up to a CPRA of around 95%. So in this group, 60 to 70% we've been able to transplant. Above 95%, we see it falling off. And so once you get above 97%, then it falls off even further. So some of these people are transplanted, but the rate is relatively low. We start to see other outcomes like getting a transplant off the list or still waiting in the pool. Our outcomes in the program are very good. So this is again from Anne's data, where we track transplant outcomes. The red line is paired exchange, the blue line is direct living donor transplants, the green line is deceased donor transplants. So 1 and 5 year graft survivals are the same as direct living donor transplants, which is a good outcome, particularly given that these patients have a much higher rate of sensitization and having a repeat transplant. So just to mention a couple of other aspects. So one of the challenges, I think, is matching highly sensitized recipients, which is something I've alluded to. And because these people are more difficult to match and take longer to match, as you go through over time in a program, you tend to have an accumulation of the most sensitized patients in the program. So this is just an illustration of that, how to get through them quickly. That's been a big challenge with COVID, but we've been trying to schedule surgery much faster to try to limit the time between matching and transplantation, because not only did we have pairs dropping out before matching, but if you have 3 months between your match and your surgery, then the rate of chain breakdown is probably 30 or 40%, which is a huge drag on your efficiency, I think. So I don't think it's disadvantaged the highly sensitized at all. And I think that there's, our experience was that we were getting patients matched faster and to surgery faster. And we think that's likely to reduce the chain breakdown and the leakage of pairs out of the pool. The other thing is, we're very keen for the compatible pairs, and compatible pairs, I think, are people who can enter but don't have to enter. And if someone's ready to go ahead with a transplant and you say, well, we can put you in the program and see if you get a match, the next match runs in 2 months' time. And if you get a match out of that, the transplant will probably be 2 months after that. It's not nearly as attractive as saying, we'll put you in the program, we can check next week whether you've got a match. If you've got a match, we'll do the surgery in a month. If you don't have a match, you can go ahead with your own donor. And so we're trying to lower that barrier to compatible pairs entering as a way of creating more matches too.
Fascinating, and we could talk about the detail. I know I could wax lyrical as well, and it's fascinating to exchange thoughts with you. Just trying to broaden the discussion out to some of the questions that have come into the chat, and obviously thinking about our audience here, and perhaps some countries that haven't got an exchange program, some countries that might be contemplating starting an exchange program. Nerissa, perhaps I could bring you in here, and Margaret too. How feasible would this be, for example, to include a group of smaller countries to join and start a program like this? What do you think the potential is for that? Is Nerissa still with us?
Sorry. Hi, can you hear me?
We can hear you, yes, Nerissa. We can't see you, but we can hear you.
Oh, let's start my video. Okay. Yeah, so I think that's a great idea. Certainly, it's one of my long-term goals. But there are many barriers, mainly financial. And I think, Margaret, you know, from what I've seen on returning to the Caribbean, a lot of political issues also. So whilst I think it's definitely needed, and it is a way forward, because, you know, as Peter just, you know, very nicely illustrated, the outcomes are very good, and we certainly don't have the resources to embark upon ABOI and, you know, transplantation or HLA. So it is a very good option, but I think we are nowhere close to that. Or what do you think, Margaret?
I agree. It'd be lovely. It certainly is a dream of mine, and I think we're getting closer with collaboration we do have a Caribbean College of Surgeons. So we're getting closer with collaboration with each other as individual countries start to develop their own programs. So, but as far as having programs, I mean, Trinidad is one of the bigger ones, and then there's us and there's Jamaica. And so we still have to develop programs within the countries at this point. There are still only about 2 or 3 that are getting there. So there's a lot of work to be done to develop programs for living donation just off the bat first. And then I think we can look at paired, because yes, the issue is donors, and there are people who we in our own small program have not matched. That would definitely benefit maybe from somebody else who might match with them in a different country. So it's something that we would look to do after we get our own act together, quote unquote, for what we do, because we're still getting there in terms of getting our program sorted out.
I thank you for that, and I can see absolutely the challenges. One of the questions that's just come into the chat is about the legal framework that underpins all of this, and that you do require a permissive but appropriate legal framework, and we're very fortunate in the UK in having that. And I think, and I'd be interested in Peter's views on this, but one of the things that has made an enormous difference to the UK programme in a way that we hadn't anticipated is the inclusion of our non-directed altruistic kidney donors, those people who spontaneously offer to donate to a stranger. And as a default now, we include them in the scheme, and we have around 100 of those donors a year, creating up to 200 transplants a year through the scheme. And Peter, I wonder if there were some previous questions in the chat about, you know, is there difference in the terms of the psychological screening, the assessment of those donors? Something I've been involved with over the last 10 years, and I'd be interested in your views. So first of all, the difference that those individuals make and how to encourage that, and secondly, if you create any differences in the way that you assess those particular.
Yeah, I mean, it's a very interesting topic, isn't it? And I think Australia's really lagged a little bit behind with the altruistic donors. So we have some, but nowhere near the rate of the UK and the US, and in fact also nowhere near the rate of New Zealand. And so we do have them. Essentially, I think their workup is very similar, although we do perhaps pay particular attention to the psychological assessment. But I think fundamentally the workup is similar. Just reading that last question, but I think, as you say, if these donors come into the program, they're really very powerful. And something that I didn't go into is the difference really between those closed loops and the altruistic donor chains. The altruistic donor chains are easier to match more highly sensitized people and to match a higher number of recipients, because you don't need to circle back and match the first donor, or sorry, the first recipient in the chain. Once you can't match the final donor in the chain, that donor donates to the waiting list. And so they are very powerful. I think some programs overseas, not ours, really fundamentally run on the altruistic donors because they, I think, are so helpful for the programs.
Yeah, I would agree, and I think I mean, one of the things that I find talking to other countries about, whether that's in Europe or beyond, that I say about this is that actually, first of all, get your legal framework to allow that to happen. Because if you allow that to happen, then you can get your clinical community on side, because if the two are mismatched, very often what will happen, and we've seen this in some of our European colleagues, they have a willingness to include these sorts of relationships and including compatible pairs, but they're limited within their legal frameworks. So if you can influence your legal frameworks and your policymakers from the outset, and actually I find it fascinating talking to these people, because what they tell us is they don't have the same feelings of obligation or reciprocity or any of those other complex emotions. They do this as a gift freely given because they have enthusiasm and opportunity. And it is I think it's a fascinating area of practice. I don't know whether Margaret, you or Nerissa, you'd comment on the sort of whether you think that there would be an appetite for people to come forward and to donate to people that they don't know, or whether this is a phenomenon. We have seen it in quite a phenomenon in the Caucasian population in the UK, but less so for our Black and Asian group. So I don't know what your experience might be in that.
I don't know. I've never met anyone. I think we have challenges with donation in Barbados. Even to donate blood. I think most people, even for blood, or certainly for going even further for kidneys, it's that wanting to give to somebody that they know. And I think very often just looking at blood donation and the blood bank and the fact that it's so low often, and you really only get that top up, and there's an appeal to from a relative or a friend. But it might happen. I don't know. I mean, it would be lovely.
I think I agree with Margaret in terms of the Barbadian population, but I think it may be possible because we have a little community of expats from the UK, and I think they may be quite keen once we raise awareness that this is needed in the country. Right now, I think we need to raise the education level of the population and just create awareness that we do have a program, and we would like living donation. But I think it may be possible, particularly for the expats, because I know they're highly involved in charitable work and always willing to help the island.
Yes,
so I think it may be possible.
It's a very important driver. Sorry, Margaret.
Sorry, just to go back to one of the earlier questions and tying in with the altruistic, somebody asked, are the living donors at increased risk of morbidity or mortality long term? And I would say living donation is a very safe operation, and I think the risk is extremely low, certainly for mortality. There was just a recent study I saw coming out from the US, and they had zero mortality in that study. But there's some morbidity, hernias and so on in the incisions. And obviously always there's a risk of developing renal disease yourself. But the screening is so fantastic for the donors. I think this is what even allows altruistic donors, because they can see then that the operation, the procedure, you live just as long and healthy as the average person. Especially they coming into the donation so healthy, they tend to, and with long-term follow-up as we do for the donors, they remain healthy. So that was a very early question back on earlier on, I think tied in with this point now with the altruistic and encouraging altruistic donation. There was a question about how do you encourage donation, period, living donation to the panel in your country. I think awareness is important.
Awareness has been critical in the UK, and awareness raising in a very focused way, because we have a very diverse population, and in particular over the concept of kidney sharing and not giving directly to the person sitting in front of me, but actually the person sitting in front of me benefits, my intended recipient benefits if I donate to somebody else. That's a concept that we've worked on over some time. Peter, what about you in that respect?
Yeah, I think that's an ongoing challenge for us. I mean, I think our rate of deceased donor transplantation has increased a lot, and unfortunately we've had was certainly a plateau, perhaps some decline in living donor transplantation. So that's something that we're trying to encourage, but we don't have a national coordinated approach to it, which I think is what we probably need. And so it's more of a hospital by hospital or unit by unit approach. And I guess we're running out of time to probably go through it, but it's there's got to be a lot of aspects to it, I think, doesn't there? From education, just awareness raising and support for people to ask family or friends, etc.
Absolutely. Well, I think you're right.
I
You're
found-
absolutely right. We're just on the hour, really. So, Margaret, shall I hand back to you to close the webinar?
Okay, thank you, Lisa. Thank you to our speakers. Thank you to the really interesting and thought-provoking questions. And I think what we've come out of this is that there are ways to increase transplantation and like these innovations. I mean, for us, the innovation obviously is very developed in other countries to increase transplantation and donation for the betterment of our patients. So I think I just want to highlight the next talk before we go, 9th of May, skin banking. It's put in the chat, and please share with everyone in your country to continue this international collaboration for transplant and organ donation. Thank you, everyone. Have a great night and morning and the rest of your day.
Bye, everyone.
Thank you, everyone. Thank you for coming.